Hi, so my name is Dr. Rodrigo Baltodano. I am a internal medicine specialist in private practice in Claremont, Florida. I've been in private practice for 20 years. My educational highlights are I'm a graduate of the University of Miami with a bachelor's degree in evolutionary biology and a bachelor's degree in Spanish literature. I went to medical school at the University of South Dakota School of Medicine, and I did my internal medicine residency training at Georgetown University, Washington Hospital Center in Washington, D.C. At first. But I asked for a year off to get practical work experience in private practice so I could carry some more experience into my fellowship after completing internal medicine. However, I had a very positive experience and during that year. In part, the unique situation is that I went to work with my father for that year. My father already had a thriving internal medicine practice, and he was independently practicing. As such, I was given the opportunity to see on the ground level all of the intricacies of private practice. I ended up deciding to stay in internal medicine and not do the fellowship route in hepatology and liver transplant because I saw the fork in the road taking me either one way into an academic employment position that had certain specific rewards, but also certain specific challenges. And on the other side, the option was to stay in private practice and look at the benefits of calling my own shots and being independent. It was a complex decision with a lot of analysis because no one has a crystal ball. And I think a lot of medical students are faced with that dilemma early on in their education. And hopefully, my story um, will give people some perspective. I am in independent private practice, as I stated. I am in a independent office building owned by me. And I do still have admission privileges to a hospital nearby so that I can still do inpatient care if I need to of my own patients. Primarily, however, I spend most of my time here in the office in outpatient care. The demographic of my patient population is typically older patient adult, running from the upper 40s all the way up into the 80s and 90s. I have a varied mix of payers, mostly Medicare and private insurances, but I do also see some concierge patients and some cash pay patients. My practice is enriched by my being able to provide outpatient diagnostic management that includes diagnostic ultrasounds as well as some nerve testing for neuropathies, as well as uh, bladder evaluations and therapies. And in addition to that, doing some anal testing and things like this. These are ancillary um, skill sets that I acquired over time, most of which were acquired in my residency. Uh, and that illustrates for whoever's watching the importance of knowing what kind of training you're going to get when you finish medical school and what opportunities for further training in that field exist for you in the future that can potentially amplify the kinds of services that you can provide to your patients. So I typically will see anywhere from 20 to 30 patients a day. My hours are typically from about 8:30 to 4 p.m. I primarily see the patients myself. I don't have any nurse practitioners or physician's assistants, although I do employ a few medical assistants, many of whom are actually pre med or college graduates who are interested in going into medicine, some of which are also maybe interested in going to PA school too. I typically will see patients in 15-minute intervals. I usually don't take lunch out of a choice so I can finish earlier. I typically do not see patients on Friday afternoons, so I could take those off. And then finally, I don't see patients on the weekends. The kinds of cases that I see are the primary internal medicine cases one can expect. Anything running from the typical sick visit with a common cold or pneumonia presentation, or more severe things, all the way to more typically chronic care management of patients who have multiple medical conditions that need to be managed and coordinated. I may typically see a patient that comes in with no new concerns, but maybe has diabetes, hypertension, high cholesterol, maybe hypothyroidism, and I will have to go through all their medications, make sure they're getting all their monitoring testing done, lab work, etc. And then I decide to order what's next on the agenda to keep them healthy and prevent problems, since prevention is the key to good medicine. Um, Typically, my patients are Spanish speaking, are English speaking, although I do speak Spanish. They are very compliant. Comes with the territory when you develop a really good relationship with your patients. And then also, I want to highlight that primary care uh, is a name given to a specific subset of care expectations, but not really, in my opinion, a specialty. So that's something that I personally feel is true. So I like to refer to myself as an internist, a practicing internist in private practice, because primary care, I think, is kind of a catch-all term that may misconstrue what you're actually doing. Um, but that's besides your question. I just wanted to throw that in there while I had a chance. What I think students need to understand the most is that in this day and age, the opportunity to go into private practice has become severely limited by the aggressive tactics of hospitals and insurance companies, as well as private equity. The more specialized you become, the more difficult it is to be independent. It's not impossible, it's doable with some geographic limitations and other things, but it can certainly be done regardless of what you want to go into, I think. What sets internal medicine apart is that the level of training that you have in residency puts you out there with a very profound knowledge of medicine. So profound that you can branch out in ways that no other specialty can. As a result, if you're a person that likes cardiology, but you don't do cardiology, or gastroenterology, but you don't do that, you can actually learn skill sets on your own, either through workshops or during training and residency, that will allow you to do procedures that may not be procedure all the procedures that subspecialists could do, but that you can still do on a limited basis, that may not be so invasive, but that still can allow you to do two things. Number one, create variety in your practice, which is enriching and helps prevent burnout and boredom. Number two, it also facilitates good care with your own patients because you are directly taking next steps to manage, diagnose, and care for them yourself without having to refer them out. And of course, in addition to that, there's also the remuneration. When you learn some of these other skill sets or you provide other services in your practice, you can generate more income. And the income that you generate can allow you to reach a level of income that is comparable to some employed subspecialists, while still yielding you the opportunity to stay in private practice, call your own shots, take your vacations when you want, and employ the people that you want to employ, and practice how you want with the protocols that you want to follow rather than the protocols that your employer wants you to follow. That was a main consideration when I had to make that fork in the crossroads decision during my 1 year sabbatical, I guess I'll call it, after residency. Um, I looked at two big um, factors: A, the independence, and B, the income. They were directly proportional to one another. In fact, the opposite is also true. Mathematically, the opposites, kind of have to be true. If you are employed, your income is going to drop versus you remaining in private practice, because when you're employed, the middleman has to take a certain portion of your income in order to make ends meet and keep the doors open. You eliminate the middleman when you directly take care of your patients yourself, and you don't have to pay an administrative overhead that's huge like hospitals do or private equity groups do. So in summary, I think it played a huge role in my decision to stay independent and in internal medicine, because I knew by doing the numbers how much insurance is paid for X, Y, or Z. I knew what I'd have to invest to be able to do X, Y, or Z, buy equipment, figure out mathematically how much I get paid if I provide this service, what my overhead would be, and add that to my income, do that for each particular service I offer in my practice. And it was a no-brainer that it came back on the positive end. So it played a huge role in me staying in private practice. That's the question of the day. I think that the future of medicine is going to change quite a bit. However, I think that the future of uh, what one would call primary care is going to be broken down into supervisory roles and practicing roles. Um, with artificial intelligence being utilized, I believe that hospitals and insurers are going to expand its use in order to minimize dependence on mid-level providers like nurse practitioners and PAs, and um, therefore drive down demand for those mid-level providers, but unfortunately at the same time increase the burden on the medical doctor that is going to be supervising whatever nurse practitioners and physicians assistants are helping on the team, because um, someone has to be responsible for the decision making of the patient care. Someone has to be liable for Morgan and Morgan. Someone has to be suable. Someone has to take the fall, and that's always going to be the medical doctor. Um, One would argue that there's going to be less need for primary care physicians or internists or family practitioners or OBGYNs, but I don't think that's true, because you need to have these people in order to take responsibility for the care. And so I think that what's going to happen is that there's always going to be a position for people in internal medicine and in family practice. In fact, it's going to increase the need for these people, because people are dying less, they're living longer, there are more people around, and there's going to be an increased demand for them. There has been an increased demand, but because of the scarcity of them, the lack of interest in those fields, coupled with the increasing number of retirees that don't die, the demand is going to go up. So it's a complex question that could take an hour to answer. It depends on the narrative and the perspective that you're using, but I think it's definitely a field that will be in high demand. However, its responsibilities, how you're going to practice, what they're going to expect from you, is going to change drastically, with the exception of independent practice. In independent practice, one thing never changes, and that is that you can call your own shots and practice how you want. My biggest piece of advice is to spend time with a internist or a family practitioner. I Particularly if you are interested in uh, being independent and learning varied skill sets, learning how to do procedures, injections in the practice, orthopedic injections, stuff like that. Remember that you are able to do these things if you learn them. and no one's going to stop you from learning them. Uh, my advice is understand that residency training prepares you to do what the system wants you to do, not necessarily what you are able to do. And ask questions. And going back to my first recommendation, try to find a independently practicing physician so that you can see how it's done, how you can learn new skill sets, how much they know compared to what you might believe they know from seeing employed physicians in the same field. Seeing the difference is critical because if, like they say, if you never try a specific dish, you'll never know what it tastes like. Okay, if you're used to eating cheeseburgers, but you never had pizza, you'll never know how good pizza is, even though they're both junk foods. So that's my advice. Try to find someone of that nature, spend some time with them, ask a lot of questions, absorb the information, and the rest your mind will do.